Bismillahirrahmanirrahim. My name is Dr. Amber Rashid, and today my topic of presentation is My Years of Morbidity under supervision of Professor Dr. Saira Afzal. In this presentation, I shall be giving a brief introduction to the measures of morbidity, what is incidence, prevalence, comparison between the both, sources of morbidity data, recent updates, and an MCQ session at the end. At the end of the presentation, the participants will be able to describe the importance of incidence and prevalence and its use in terms of prevention and controls of diseases. So morbidity measures are, morbidity is actually the departure, either subjective or objective, from the state of physiological well-being. Or we can say that morbidity is the sickness, illness, or the disability. And it's normally measured in 3 units. One is in terms of morbidity is usually defined in terms of either frequency of disease, either it's the incidence and prevalence, the duration of the illness, the days, months, and years, and the severity of the illness, the case fatality rates. Problems with numerators and problems with denominators. Whenever we are getting these rates, calculating these rates, we can get problems with numerators and denominators. Like problems with numerators, for example, who has the disease, or the population or the people target population, who to include in the numerator, and maybe there is some kind of errors or bias. Or problems with the denominator is selective undercounting, and everyone in the denominator must have the potential to enter in the numerator group. Or there can be problems in the selection of the data, either the hospital data from the registries, or maybe due to the selective reasons like unavailability of the complete data. So what is incidence? So incidence is the number of new cases, meaning that there is an whenever we are calculating, we select a target population or the population without disease at baseline, and the number of new cases of the disease, and it's a percentage, so we multiplied it with 100. So the population during a specified period of time is selected, and the number of new cases are calculated. Similarly, the incident rate, the incidence density, is defined as the number of new cases of the disease and person time at risk. Person time meaning that this is the second form of incidence rate, also known as incident density, that we take the number of people exposed for a number of times. In a population, every person is not exposed for the same period of time to a specific risk factor. So whenever there is a chance of such in different time periods of exposure, then we use this incidence density. So for the incidence proportion, the example is that whenever we take several cases, and we place a timeline between some period like a 1 year or 1 month, then all these cases that are marked red are the new cases for the disease between the timeline, that appeared between the timeline, and the tick marks are the population at risk. So the total new cases can be calculated by dividing 4 by 6. So this is this incidence proportion. So these incident rates usually refers to the new cases over a period of time with population at risks, and new spells and episodes of disease in a given period of time per 1,000 population. Also know this proportionate period, this proportionate incidence is also known as the cumulative incidence. The calculation is the same, but the questions can be asked with different terminologies. So the cumulative incidence is a simple measure of occurrence of disease or health status. Unlike incidence, it measures the denominator only at the beginning of the study. This is the difference from the whenever we are generally considering the incidence rate. And in statistical sense, the cumulative incidence is probability that individuals in the population get the disease during a specified period of time. So cumulative incidence, we consider the period can be of any length, but is usually several years or even a whole lifetime. And cumulative incidence rates, therefore, is similar to the risk of death, like life through life tables. And the simplicity of cumulative incidence rates make them useful when communicating health information to the general public. So there are also some special incidence rates like attack rates and secondary attack rates for the or the hospital admission rates. So for the attack rate is an incidence rate, but usually expressed as a percent and used only when the population is exposed to the risk for limited time period, such as during an epidemic. For example, for calculating the number of new cases of specified disease during a specified time interval and the total population at risk during the same time interval multiplied by 100, since it is a percent. For the secondary attack rates, it is that the whenever the person when a primary case, when it transmits or transfers the infection to the other people, they are the secondary cases, and these secondary cases can be calculated by using this formula of secondary attack rate, meaning that the primary case is excluded from both numerator and denominator. That is the most important part whenever you are calculating the secondary attack rate. For example, number of exposed persons developing the disease within the range of incubation period. This is important, that when the persons were exposed to the primary case, then during the incubation period, how many persons developed the disease after exposure. Divided by total number of exposed or susceptibles into 100, it's also a percentage. But there are some limitations to this secondary attack rate that's useful only for the diseases with short incubation period and not possible to identify the susceptible cases. So this is an example of secondary attack rate. That is the number of exposed person developing the disease within the range of incubation period following exposure to a primary case. So, in the family of persons of 6 persons, consisting of 2 parents who are immune to a specified disease like chickenpox, and 4 children susceptible to chickenpox. One child develops chickenpox, and after some times, 2 children develop among the three. So, the secondary attack rate would be 2 divided by 3 into 100, as out of all 4 children, one was the primary case. So, the primary case was excluded from both numerator and the denominator, and only 2 children developed the disease out of the three remaining. So, 2 out of 3 into 100, so that attack rate, secondary attack rate was 66%. Whenever we are considering the cases and we are focusing on the deaths due to the specified disease in a specified population in a given time period, then it's the case fatality rate. For example, out of 10,000 people, these 20 people died. Then the answer would be 20 divided by this 10,000, and the answer would be the case fatality rate. So for this reason, we are only focusing on the total total deaths that have been occurred in the specified period due to a specified disease. Uses of incidence rates, it is useful for taking actions for control measures and also for the research purposes in etiology and pathogenesis and distribution of diseases, efficacy, prevention, and therapeutic measures. Second indicator for morbidity is the prevalence. So prevalence is all current cases, old and new, existing at the time, and it's the total number of individuals who have an attribute or a disease at a particular time divided by population at risk having the disease. So the denominator was having the disease or the disease population. In terms of incidence, it was the healthy population. Two types of prevalences are there, either point prevalence and period prevalence. So the point prevalence is all the current cases, meaning new and old cases at one point in time over an estimated population, whereas the period prevalence is during a specified time interval. Estimated mid-interval population or mid-year population at risk is the denominator for period prevalence. So for the point prevalence, since it's the number of old and new cases at a given time period. So in this case, this line demarks a date. For example, it's some month in 2000s, and we have to only calculate on this date, or this time in this time point. So all the red marks would mark the cases, and the blue marks are the all the population at risk. So four cases are crossing this timeline, showing that these cases have uh, occurred during this point. So this would we can calculate by this calculation. For the period prevalence, we are considering the time period between two time intervals. For example, between June 2020 to December 2020. So all these orange cases, these are all representing all the new and the old cases between these specified timeline. So all the seven cases out of the population risk 9 are all the cases that have been occurred. So it would be 7 out of 9, and that would give us the period prevalence. There is a relationship between prevalence and incidence, and it is that prevalence is equals incidence into duration. If the population is stable and the incidence and the duration are unchanged, then this relation is then prevalence is directly related to the multiplied sum multiplied of multiplication of incidence and duration, meaning that longer the duration, greater the prevalence, for example, in TB. So for the acute diseases, short duration and rapid recovery, so prevalence is less than incidence. So this is the relation between the two. So what are the factors that influencing the observed prevalence rates? Longer duration of the disease, prolongation of life without care, increase in new cases, out-migration of non-diseases, in-migration of susceptible diseases, and improved diagnostic reporting. Prevalence overall can be used to estimate the magnitude of a health problem, of a disease in a community. It also helps to identify the potential high risks and useful administration and planning purposes. So, whenever we are considering a community, so we see some comparative factors that affect the prevalence rates. What factors causes an increase in the overall prevalence rate? Number one is the by immigration of ill cases to a community, immigration to of a healthy persons, immigration of susceptible cases or those with potential of becoming cases, prolongation of life cases without cure, increase of duration of disease, increase in the occurrence of new cases, and increase in the incidence, all increases the prevalence rate in a community. Whereas the factors that decreases the prevalence rates in the overall prevalence rates in the community is by the immigration of the healthy persons, immigration of ill cases, improved cure rates of cases, increased death rates from the diseases, a decrease in occurrence of new cases, short duration of diseases, and death. So there are several sources of morbidity statistics like clinical and hospital data, registries, vital statistics, surveys, disease reporting systems, insurance and prepaid medical care plans, and the absenteeism records in some countries. How this morbidity data can be used? It can be used to describe the disease load in the community and assist in establishment of priorities. It can also provide more comprehensive, accurate, and clinically relevant data essential for basic research and monitoring and evaluation of disease control prevention activities. So these are the uses of this whole morbidity data. So whenever we are comparing the prevalence and incidence, so the characteristics in terms of risks is the probability of disease. In prevalence, the percentage population with the disease, whereas in incidence, there is the probability of the rapidity of the disease occurrence. Prevalence has no units, but incidence can be calculated in terms of person time. And for calculation of person time, you only have to multiply the time of exposure with the total number of persons that have been exposed during that period. Newly diagnosed cases, they are existing in the prevalence, and they are also existing for the incidence rates. For the cumulative incidence, that is known as the incidence density, in which we take the population at the start of the specified time period. So, several differences is that the numerator is the new cases for the incidence, wherein the prevalence is it is the all the existing cases. Denominator in both is the population at risk. The focus for the incidence is whether the event is the new case and the time of onset, whereas the for the prevalence is the time, presence or absence of the disease, and time period is arbitrary. And usage is to express like the risk of becoming ill and the main measures of acute diseases, whereas it estimates the probability of population being ill, and useful in study of burden of chronic diseases and implication of health services. So, concluding the whole presentation is that the whole discussion, we can list the basic measurements. The basic measurements in epidemiology could help in selection of an appropriate tool for the morbidity and mortality measurements in the country, and also with along with the standardization of the rates, we can find the accurate statistics, and we can which can help in the policy making and the control and prevention of the disease. So some of the recent advances is that prevalence estimation, how it is done and how human trafficking is controlled, meaning that how the population is selected. So one important point is how the population is reached for the prevalence measurement, also known as the human trafficking. Previously, several methods were used. Now, for human trafficking, new methods have been included, like network-based approaches such as respondent-driven sampling and the network scale-up methods, and venue-based methods and respondent-driven samples. So one point in calculating these rates is to how to get the target population. We nowadays these methods are used. Secondly, showing that the variation in estimated prevalence of multimorbidity. Second point to consider in terms when we are calculating these incidences and prevalences is that we can get different prevalences in different areas. So it all depends on the statistics of the population that is under consideration, the demographic distributions, and the other factors that affect the prevalence. Like in this paper, there was a variation as a variation, and it was a meta-analysis done, and it concluded that the pool prevalences of multimorbidity was significantly higher in older population, and when the studies include a large number of baseline conditions. So it is one of the cases, but the point is to highlight is that the prevalences vary in different situations based on the different socio-demographic factors of a specified community. Third is that these rates can help us deciding and in for the decision of an intervention. For example, this paper was done for the surveillance of tuberculin test and polymerase chain reaction to determine the presence and prevalence of avian tuberculosis in layers. And this study was done in Nigeria. So the study concluded that we have demonstrated the existence of ATAB in several areas of this. And this also revealed that the prevalence was 41.7, which signifies the need of tuberculin tests in all the layers and breeder farms, and confirmed the status of ATB on farms. And we have also revealed that lack of knowledge with regard to availability and relevance of tuberculin test among these farmers was the main case, was the main reason. So it is also, these rates are also helpful for us to decide the intervention. This was regarding the secondary attack rates, how the secondary attack rates help us to assess the help us in severity analysis and deciding the interventions for the control of the disease. Like this paper was done in epidemiological and clinical features of SARS-CoV-2 clusters in China. The secondary attack rate was 7.1 for the index case and so on. But in severity analysis, the data showed that most patients were mild and moderate, and more severe patients were seen in generations of patients and in the index. So the numbers doesn't matter here, but the point is that the secondary attack rates, whenever calculated, can suggest that the secondary attack rate decreased over a propagation or increased, or what are the patterns of the severity of the disease, how much it is transmissible, and how fast it is transmitting it in the community, and what preventive measures we can take. And the last is the simultaneous crisis of dengue and COVID in Pakistan. So I would like to take opportunity to just highlight the problem that is currently the higher incidence of dengue virus in Pakistan since January 2021. So the health officials should identify there are efforts being done. Health officials are trying to identify the breeding grounds. Dengue surveillance is integrated nationwide and system information systems, but there is still need improvement. Multi-sectoral dengue action committee has recommended an emergency action plan, and steps are being taken up. Education and awareness of people is being raised through social media and multimedia as well. And municipal authorities vigilant during rainy seasons, so these are also playing an important role, and it is a prime importance. So as COVID-19 is also prevailing in our society, so there is an overlapping of symptoms. So there is a need for extensive testing, and due to these overlapping systems, patients and people should be given awareness regarding these distinguishing features of both the diseases. Thank you. Now it's time for the MCQs. First one is a simple one. As a study starts with 5,000 people, and of these 125 have the disease in questions. So how can you calculate the prevalence per 1,000 people? Any idea?
Peter?
It would be 125 divided by this 5,000 into 1,000, and the answer is 25. So the main concept is that whenever we have a starting population and we have a total number of disease, so we only simply divide it and multiply it with 1,000. Second is that a study start with this much people that are healthy people, and think of these as 5,000 from just ignore this line. Over the next 2 years, 75 develop the disease. What is the incident rate of the disease over the study period? If you are starting with this population and over the period of next 2 years, 75 cases develop, then what is the incidence rate of the disease? I know it's difficult to calculate in such a short period, but just to give you a concept, the answer would be roundabout this option. I'll show you how. That whenever you are given a time period, then and a total number of persons who develop the disease, then it is important to consider this time period in the denominator. That was the concept I was about to give. Like 75 over this population in 2 years. Sorry, these were the cases. This will be the numerator. These are all the cases that have been exposed over the period of 2 years, and 75 developed the disease. So out of 75, 4875 into 2 years, then we get the answer of this, and in 1,000 population it's 7.69. I hope you get the concept. In which one of the following circumstances will the prevalence of the disease in the population increase, all else being constant? If the incident rate of the decrease falls, if the survival time with the disease increases, if recovery of the disease is faster, if the population in which a disease is measured increases. When prevalence of the disease in the population, yes, it's beta. If the survival time with the disease increases, it's beta. Many of the students at the boarding school, including 6, just coming down with varicella, went home during the Thanksgiving. About 2 weeks later, 4 siblings of these 6, 4 siblings out of these 6 students, and the total 10 siblings developed varicella. The secondary attack among the siblings would be. Any idea?
Peter?
It would be total 10 siblings.
C.
Yes, will be the right answer. C would be the right answer. Like if 4 out of 6 students are having the total 10 siblings, 4 developed and 6 returned, and only 4 developed, then it would be 4 out of 10. Use of the following diagram of question, using this diagram, assuming the horizontal lines, what is the prevalence of the disease in July? Either it's considering that these are the community of 700 people, 3 out of 700, 4 out of 700, 5 out of 700, 8 out of 700.
A.
Yes, it's 3 out of 700. In an outbreak of cholera in a village of 2000 people population, 20 cases have occurred and 5 died. What would be the case fatality rate for this?
B.
Yes, it would be D. It would be 5 divided by total and into the number multiplied, then the answer would be D. So in this this is slightly longer, but there is an important concept. This was done. This study was done for tuberculosis in a village of India, and the number of cases were determined in terms of incidence rates in two categories. The category of household first survey number were 500, and out of these 500, the number of new cases with culture positive were 10, and um, with culture negatives, for this situation, 500 people, the culture positives were 10, and out of 10,000 cases, only the culture positive without culture positive means culture negative cases, only they were also 10. So what is the incidence of new cases in household who have the culture positive cases during the first survey? Only considering this part, that 5 out of 500 persons, the new cases for the culture positives were 10. The solution to this is very simple, that there were 10 cases and 500 persons, and at 2 years and the timeline was given was 2 years apart. So we only consider 10 cases, 500 persons for 2 years exposure multiplied by 1000, then we get the answer 10. So D is the right option. In a population of 1000, measles coverage is 60%. One child goes out of station and comes back with measles, from whom 20 more children gets measles. So the secondary attack rate for measles is 0.655, 6%, 6.5, or 7%.
C.
Close, it would be 5. I'll show you how. The total number of children 1000, number of immunized this, number of non-immunized this. Primary case was 1 and 20 caught the disease. So from the unimmunized 400, the secondary attack rate would be 20 divided by this, and it would be 5%. So B is the right answer. When the total number of deaths due to measles is presented in relation to the total cases of measles, it is best labeled as what?
D.
D.
A.
D.
It's D. When the total
Yes.
number of deaths due to measles is presented in relation to the total cases of measles, it would be case fatality rate. An expert in the field of public health to estimate the magnitude of health problem. Magnitude of health problem. What rate would he calculate for this? For the magnitude of the health problem.
Prevalence.
Yes, it
B.
would be prevalence. So for the magnitude of a health problem, we use prevalence, not incidence. So this is the key, and thank you.
Thank you very much, Dr. Amber. Very nice presentation and brilliantly done. Very well done. Allah Hafiz.
Allah Hafiz, ma'am.